Hello everybody and welcome to our module on other anemias. By way of review, anemias can be divided up by the size of the red blood cells. There are microcytic anemias where the red cells are small, there are normocytic anemias where the red cells are normal in size, and then there are macrocytic anemias where the red blood cells are large. We have another module on the microcytic anemias, and I have a couple of modules on the hemolytic anemias. In this module we're going to focus on these last two groups of anemias, the normocytic non-hemolytic anemias and the macrocytic anemias. Let's start with the normocytic anemias. Normocytic anemias are anemias where the MCV is between 80 and 100, which is the normal range. And normocytic anemias can occur because of hemolysis, but they can also occur because of underproduction of red cells from the bone marrow. These are called non-hemolytic normocytic anemias. There are a couple of reasons you can have underproduction of red cells from the bone marrow. First of all, this can occur when the iron level is low. In the module on microcytic anemias, I talked about iron deficiency anemia and anemia of chronic disease, and you always want to remember that these two causes of anemia can lead to either a microcytic or a normocytic anemia, and I explain that in the module on microcytic anemias. In this module, we'll talk about low EPO levels, which occur in patients who have renal failure, and also patients who have problems with their bone marrow. If there's a problem with the bone marrow, this can lead to aplastic anemia and other anemias where red blood cells are not produced in the normal amounts. First, let's talk about EPO, which is erythropoietin. This is the stimulus for red blood cell production from the bone marrow. EPO is synthesized in the kidney. Specifically, it's synthesized by interstitial cells of the peritubular capillaries. These are found in the cortex of the kidney. I've shown a drawing on the screen of a glomerulus, and next to the glomerulus you can find the peritubular capillaries. Interstitial cells around these peritubular capillaries will release erythropoietin. It's released in response to hypoxia, and there is decreased production when there is renal failure. This should make sense to you. If the kidney is damaged and failing, the interstitial cells of the peritubular capillaries will not be functioning normally, and they will not produce the normal amounts of erythropoietin, and this can lead to a normocytic anemia. Basically, the bone marrow is simply being understimulated to produce red cells. And just to make the anatomy very clear, this is a picture of the kidney. The renal cortex is the outer layer of the kidney. This is where you can find the glomeruli. The peritubular capillaries are also here, and this is where the interstitial cells sense the oxygen tension and release erythropoietin when the oxygen tension is low. The place where you will most commonly encounter EPO on your clinical rotations is when it's given as an injection to patients who have kidney disease and anemia. There are several synthetic forms of EPO which can be prescribed. One's called darbepoetin, the other's called epoetin. They're both used to treat the anemia of chronic kidney disease. Basically, this will replace the EPO that is lost because the patient's kidneys are failing. Now, EPO injections used to be administered more regularly to patients with chronic kidney disease and anemia. However, the FDA issued a black box warning in the last few years. There's an increase in mortality among patients receiving EPO injections. The mechanism of this is not clear, but for this reason, EPO injections are now generally reserved for patients who have a severe anemia. They're not given to patients with milder anemias and chronic kidney disease. The next cause of normocytic anemia we'll discuss is aplastic anemia. This condition results from loss of hematopoietic precursors, the stem cells in the bone marrow. Calling it an anemia is really a misnomer. This condition leads to a pancytopenia because of loss of stem cells. There will be low white cells, low platelets, and also low red blood cells in aplastic anemia. Let's pause here and review a little bit of vocabulary. The word aplasia means defective or absent development. So aplastic anemia means anemia where there is absent development of red blood cells. Bone marrow failure refers to an inability of the bone marrow to produce cells. This results in pancytopenia, and there are many causes of bone marrow failure. For example, fibrosis of the bone marrow can cause bone marrow failure. Infiltration of the bone marrow by tumors can cause bone marrow failure. Sometimes you will hear the term used myelothisis. This means displacement of the bone marrow tissue by something else, for example, fibrosis or tumors. So once we understand those two terms, we can understand aplastic anemia. This is a specific subtype of bone marrow failure in which there is aplasia or defective stem cell function that leads to abnormal development of the red cells, the white cells, and platelets. And this will result in an acellular or hypocellular bone marrow because the stem cells are not producing the cells they normally should. So once you understand that vocabulary, you can understand the two hallmarks of aplastic anemia. First of all, there is pancytopenia, but pancytopenia alone is not enough because there are many causes of pancytopenia. The second hallmark of aplastic anemia must also be present, and that is an acellular or hypocellular bone marrow. This is seen when a bone marrow biopsy is done for diagnosis. You will see an absence of cells and replacement with fat. This is a picture of a bone marrow biopsy from a patient with aplastic anemia, and you should get used to this picture. You can find lots of examples of this online. online and in textbooks. It's a classic picture where there's lots of fat and very few cells. This is what is seen in aplastic anemia. The symptoms of aplastic anemia all result from the pancytopenia. There are normal cells but not enough of them being produced. So these patients will have a normocytic anemia and they can develop fatigue and pallor from the low red blood cell count. There will be thrombocytopenia, which can lead to bleeding, and there will be leukopenia, which can lead to infections. The syndrome of aplastic anemia has a number of causes. Most commonly it is idiopathic, but there are a number of other potential causes that I've listed on the screen here, and we'll go through all of these in the next few slides. So the idiopathic form, the most common form, has an unknown trigger. However, you should be aware that there is now strong evidence in the literature of an immune-mediated mechanism. Specifically, there's evidence of T-cell mediated destruction of stem cells that may lead to idiopathic aplastic anemia. Some of the evidence for an immune-mediated cause of aplastic anemia comes from the fact that there are two commonly used immunosuppressive agents which can treat aplastic anemia. The first one is called antithymocyte globulin. These are animal-derived antibodies against human T cells. Usually they come from rabbits or horses, and they can improve the symptoms of aplastic anemia. This medication is also sometimes used in patients who have received kidney transplants. And then the second drug that's sometimes used is cyclosporin, which I talk about in more detail in the immunology modules on immunosuppressants. Radiation is another well-described cause of aplastic anemia. Aplastic anemia occurred in many of the survivors of the atomic bombings in Hiroshima and Nagasaki. It also occurred in survivors of the Chernobyl nuclear accident in Russia. The way this happens is that radiation damages the stem cells, and this leads to aplastic anemia. Certain industrial chemical exposures can cause aplastic anemia. The classic chemical agent to do this is benzene. This is a picture of a benzene ring on the screen to remind you of that. People can be exposed to benzene when they work in rubber factories or shoe repair shops, especially if there's poor ventilation. There are a number of drugs that can cause aplastic anemia. You may be aware that most chemotherapy drugs will lead to a reduction in the white blood cell count, the red blood cell count, and the platelets. This is an anticipated effect. The drug is being administered to stop the growth of the cancer, but it's anticipated that it will also stop the growth of stem cells, and for this reason, monitoring of patients' blood cell counts is very important when they're receiving chemotherapy. Chloramphenicol is a rarely used antibiotic. It works as a bacterial protein synthesis inhibitor, and it's been associated with aplastic anemia. Phenylbutazone is an old NSAID. It's not used anymore. It was pulled from the market due to cases of aplastic anemia. And then finally, two drugs used to treat hyperthyroidism, methimazole and propylthiouracil, have been associated with aplastic anemia, and for this reason the white blood cell count and the complete blood cell count are often monitored in patients taking these drugs. There are others, but these are some of the ones that have been commonly associated with aplastic anemia that I've listed on the screen here. Viruses can also lead to aplastic anemia. One of the viruses that classically does this is parvovirus B19. Now you may know that this virus usually infects proerythroblasts, and it usually causes decreased red blood cells only. This is sometimes referred to as red cell aplasia. However, in some cases the virus can also damage the other cell lines and cause pancytopenia, and this is more likely to occur among patients who are immunocompromised. They have decreased defenses against the virus, and thus it's able to cause a more severe infection and lower not only the red cell count but also the white cell count and the platelets. Aplastic anemia is also associated with acute viral hepatitis infections. These can lead to aplastic anemia. Aplastic anemia has been reported after acute hepatitis from all of the hepatitis viruses, Hep A, B, C, D, and E. For reasons that aren't well understood, this often occurs in boys and young adult males who develop acute hepatitis, and the aplasia doesn't occur at the same time frame as the hepatitis. It usually happens weeks or even months after the acute hepatitis has resolved. There are other viruses as well that have been associated with aplastic anemia, including HIV, Epstein-Barr virus, and cytomegalovirus. In all of these cases, the pathophysiology of aplastic anemia is not understood, but it's believed that it's probably not caused directly by the virus. There is evidence that this also may involve T-cell activation like we talked about before. And finally, Fanconi anemia is an inherited form of aplastic anemia. It's inherited in an autosomal recessive or X-linked manner, and it usually presents in childhood, usually in children less than 16 years of age. And more than half of these children have some physical deformity, and this is how you can recognize this rare syndrome, especially in a board question. So many of them have short stature, many of them have cafe au lait spots on their skin. Malformed thumbs is a very unusual and classic finding in children with Fanconi anemia, and there are many other abnormalities that have been described, including abnormalities of the heart, like congenital heart defects, also kidney and eye problems as well. A number of genetic abnormalities have been identified among children with Fanconi anemia, but you should be aware that many of them involve DNA repair enzymes. Many of these children are hypersensitive to DNA damage, especially abnormal DNA strand crosslinks. And because they have problems with DNA repair enzymes, this puts them at increased risk of malignancy. And children with Fanconi anemia have higher rates of myelodysplastic syndromes, AML, and also squamous cell carcinoma of the head, neck, or the vulva. The treatment of aplastic anemia is complex. I'll just highlight some of the principles for you here. First of all, you want to stop the offending agent if aplastic anemia is the result of a drug or an industrial exposure. Transfusions are often required, transfusions of red cells and platelets. There are drugs which can stimulate the bone marrow. You can administer erythropoietin to drive red cell production. GM-CSF is granulocyte macrophage colony stimulating factor, and G-CSF is granulocyte colony stimulating factor. These can both be administered to increase the white blood cell production from the bone marrow. As I mentioned before, immunosuppression is sometimes done with anti-thymocyte globulin and cyclosporin. Other immunosuppressants are also sometimes used. And then finally, bone marrow transplant can be curative in patients with aplastic anemia. A rare and somewhat related disorder to aplastic anemia is pure red cell aplasia. In this disorder, there is absence of the erythroid precursors in the bone marrow, and this leads to a marked reduction in reticulocytes and an anemia. Importantly, however, there are normal granulocytes and platelets. This is usually an idiopathic disorder, although it is also associated with some drugs and viral infections, just like aplastic anemia. And the most important thing to know about this disorder, especially for taking step 1, is that it is associated with thymoma, which is a rare tumor of the thymus. This is present in 5% of cases of pure red cell aplasia. Now we'll talk about the macrocytic anemias. These are anemias where the MCV is higher than normal and greater than 100. There are two general categories of causes. The first cause is abnormal DNA synthesis. This results in macrocytic anemias that are called megaloblastic. We'll talk about those in a minute. And then there's a small group of other causes. These include liver disease, alcohol consumption, and reticulocytosis. We'll also talk about all of those. Megaloblastic anemias are anemias where red blood cell precursors grow but cannot divide normally. So this is like the opposite of microcytic anemias, where red blood cell precursors divide too much and make small cells. Megaloblastic anemias result from abnormal DNA synthesis. The cells cannot efficiently make DNA for cellular division, and thus they grow in size but they do not divide normally. The findings in megaloblastic anemias include an anemia. There will be a low hematocrit and low red blood cell count, just like the name implies. The red cells will be large. They will have a high MCV. But what defines megaloblastic anemias and what differentiates them from other macrocytic anemias is the presence of hypersegmented neutrophils on the peripheral blood smear. The reason these develop is because the white blood cells, including the neutrophils, also cannot divide effectively due to decreased DNA synthesis. As a result, the neutrophils will develop hypersegmentation of the nucleus, and hypersegmentation means that there are greater than 5 lobes. This is a picture of a hypersegmented neutrophil shown on the screen here. You should get used to seeing this picture and be able to recognize it because it's commonly shown in exams to test whether students can recognize that that is a finding that indicates a megaloblastic anemia. There are a number of causes of defective DNA production that can lead to a megaloblastic anemia, and if you're preparing for step 1, I recommend that you learn all of these causes from the biochemistry perspective. In the biochemistry modules, I talk about folate deficiency and vitamin B12 deficiency in detail. These are two classic nutritional deficiencies that can lead to megaloblastic anemia. Orotic aciduria is also an inborn error of metabolism that can lead to a megaloblastic anemia. And then finally, there are some drugs which interfere with DNA synthesis. These include methotrexate, 5-fluorouracil, hydroxyurea, also drugs used to treat HIV like zidovudine. All of these can impair DNA synthesis and lead to a megaloblastic anemia, but I discuss all of these things in much greater detail in the biochemistry section. Finally, let's discuss the non-megaloblastic causes of macrocytic anemia. These are conditions where there's macrocytosis without impairment of DNA synthesis. The first one is liver disease. The exact mechanism of macrocytosis in liver disease is not known. However, increased lipids are seen in the red cell membranes of some patients with chronic liver disease, and this is hypothesized to contribute to the higher than normal size of the red cells. Second cause is alcoholism. This is a common cause of macrocytosis, and this can be very helpful clinically. Many patients deny or underestimate the amount of alcohol they consume. However, if you see that the MCV is elevated, it suggests that the patient is a heavy drinker. The mechanism is not clearly understood, but it's believed that acetaldehyde may induce membrane changes in the red cells that lead to the increased MCV. Recall that ethanol is metabolized by alcohol dehydrogenase into acetaldehyde, and therefore there can be increased amounts of acetaldehyde in patients who are alcoholics. The final cause of a non-megaloblastic macrocytic anemia is reticulocytosis. The reason this is listed in textbooks as a potential cause of a macrocytic anemia is because reticulocytes are bigger than normal red blood cells. Reticulocytes have an MCV of about 100 to 125. Normal red cells have an MCV of about 80 to 100. So in theory, if you had a normocytic anemia with a very high reticulocyte count, this could lead to a macrocytosis. To understand this, imagine that we have a normocytic anemia with some normal-sized red blood cells, and then we also have some much larger reticulocytes present. If we took the mean size of all of these cells, we could find that it was increased, and we could call this a macrocytic anemia, even though it's really a normocytic anemia with lots of reticulocytes present. Now, you should be aware that many experts doubt that this ever actually occurs in clinical practice. The reason is because reticulocytes are only about 20% bigger than normal cells. So if you do the math, you would need lots of reticulocytes to raise the average MCV to greater than 100. What actually happens in clinical practice is that the reticulocytes raise the average MCV slightly, but they don't raise it so much that it becomes greater than 100 and gives the appearance of a macrocytic anemia. But nevertheless, reticulocytosis is listed in many textbooks as a cause of a macrocytic anemia. And that concludes our module on other anemias.